Good afternoon, everyone, and welcome to this edition of MacroPro and Friends. I am Graciela Ojeda with MacroPro, and I am joined today by our expert, Paige Salinas. Before we get started on today's program, I have a few things to go over. First, today's program is worth 1 hour of California CEU credit. You must be logged on to GoToWebinar in order to receive the credit. Please make sure you clicked on the link which was emailed to you from GoToWebinar so they can track your time and attendance. Unfortunately, you will not receive credit by just listening in on the phone. There are some handouts for today's presentation that are attached to the control console, so please make sure you download these. If you have any questions for our speaker, please make sure to put them in the chat box. Paige will do her best to get to all of your questions. Lastly, if you would like to see this program again, it will be posted on the MacroPro YouTube page. You can also find a lot of great educational information from previous trainings there. I am now going to turn this over to Rhonda Rios from Learning Services, who will introduce our speaker. Hello, Rhonda. How are you?
Hello, Graciela. How are you today?
I'm doing great. Thank you so much for being here today. We're so excited to hear about your program. Can you explain a little bit about what you do?
Absolutely. Again, thank you for having us here today to present ethical challenges in post-acute brain injury treatment. So here's a little bit of information about our company and programs that we offer. Learning Services, along with our other Collage rehabilitation partners, offer a national continuum of post-acute brain injury rehabilitation programs. We offer neurobehavior rehab, post-acute neuro rehab, supportive living, home and community neuro rehab, community and outpatient, and day treatment. And now a little bit about our speaker. Paige Salinas is our Vice President of Clinical Operations, West Region for the Learning Services, a Collage rehabilitation partner. She has a clinical and operational oversight over learning services in Colorado, Utah, and Northern and Southern California, where she leads our managers and interdisciplinary teams toward client-centered practices. In addition, she serves on the board of governors of ACBIS, which of course is the Academy of the Certification of Brain Injury Specialists, creating and expanding and improving education and certification options for people working in the brain injury field. Paige is also a surveyor for CARF International, the Commission on the Accreditation of Rehabilitation Facilities. Paige has been working in the neurorehabilitation field for almost 20 years. So now I'd like to hand the presentation over to Paige. Welcome.
Thank you, Rhonda. Definitely excited to be here today with you guys. So thanks for hanging out with me this afternoon. Hopefully you've had some lunch and some caffeine, hopefully not too big of a belly there, so that you can sit for the next hour and hear about ethics. So I will try to keep it as lively as possible as we talk about this topic that we are all definitely tied to in some way, shape, or form. And so I'm excited to be able to talk through the ethical challenges for case managers, but also for rehab professionals over the next hour as we come together and talk through that. So the presentation really is targeted towards case managers, towards nursing, but also just in general, our rehabilitation professionals, right? But when we talk about and we hone in on case managers, I have been a case manager for many of years in my former roles, and I can attest to this, that we do it all, right? There is so much coordination and management of care for the individual that is injured and or has some type of disability. And so when we're working with these individuals, we're really focusing on work-related and non-work-related injuries, and really kind of coordinating the care. I often talk about case managers being the hub, right? Because the coordination of care that takes place, you have to be at the center of every single thing that we do. And there's also that coordination piece, right? And the level of expertise that comes with that to be able to build partnerships, to develop that trust and rapport, but also focusing in on our work with the clients and our work with the families. And oftentimes that comes with crisis intervention, that we work with together with our interdisciplinary teams, and also counsel, right? We become that individual that everyone is looking towards for answers. When we think about the crisis intervention piece, it's the crisis occurs and who's the first person they call? The case manager, and that oftentimes for you know, our payer relations, whether it's the family members, whether it's the attorneys involved, we as case managers are that direct point of contact. There's also opportunity in the case management role to promote health. And obviously, as we are working with individuals that have suffered some type of brain injury per se, or illness or injury, we're also looking at ways to reduce potential risk as we move forward with these individuals, right? There's a lot of comorbidities that accompany that injury, and lifestyles, previous pre-morbid lifestyles that we really want to focus in on. How do we reduce those risks as we move forward? And then we're also dealing with those legal and regulatory compliance aspects of our role, and really looking at the workplace setting and detecting those hazardous areas that would be preventative for the individual to be able to return to work. So again, I applaud each and every one of you. If you are a case manager or have been a case manager in past years, I have great respect and admiration for the role that you fulfill and how you are such a great influence into the services that are provided for individuals. So going into kind of why are we talking about ethics, we have to be able to have some standards, right? When we think about what guides us, what anchors us into what we do and how we do it, it's through our code of ethics, right? And so these standards are really that professional conduct rooted in moral principles and values of society and the profession. And so when I think about ethics, I think about values and morals. Those are kind of the buzzwords or the keywords that come to mind. But in addition to that, there's also the legality, right? There's so many legal rights, but those ethical standards have to exceed those legal rights. And there's other entities that help us guide our ethics and our performance and codes, which includes regulatory boards, right? Employers, policy and procedure. That's what guides us as well. And then other professional organizations, whether it's, you know, NASW or, you know, PTA, APTA, whatever it may be, whatever discipline you are in, there are professional organizations that have those code of conducts, in addition to your state regulations that we have to abide to as well, right? So for this presentation, I chose to pull two different code of ethics, just thinking and kind of staying with the theme of case management. Oftentimes when we're working with case managers, at times, and for the majority, the individual has background within social work and or nursing. And so I pulled those code of ethics because I think it's important for us to actually take a look at what we're looking at, right, when we're talking about code of ethics. And so again, here's those words, right? Moral document, professional values, our standards, how we practice integrity in the work that we do. And I wanted to quote this because I think it's compelling in the way that we're talking about ethics. It's a systematic approach to understanding, analyzing, and distinguishing matters of right and wrong, good and bad as they exist along the continuum and as they relate to the well-being of and the relationships among sentient beings, right? So what we're really focused on is this a good move? Is this a bad move? And really kind of, we can all get in a room and have a difference of opinion, but truly our code of ethics really allows us to focus in on those things that are important standards of behavior that really guide us in the way that we behave with the individuals within that hub that we're interfacing with. And this is very similar. So if you pull code of ethics across all disciplines, you're going to see a lot of similarities and really kind of with the same goal, right? We want to be able to offer a set of values, there's that word again, principles and standards to guide decision-making and conduct when ethical issues arise. It's not prescriptive, right? It's not a set of rules how social workers should act in all situations, but it's specific applications of the code that do have to be taken into account given the context, which sometimes can be gray, right? We talk about code of ethics and there's this black and white, this dichotomous thinking, but really in reality, there's a lot of gray areas. And that's why we have to pull from multiple sources as we're looking at our ethics, our code of ethics, the regulatory items, as well as the professional organizations, all of the things that I listed before, right? That's what we're all pulling from to be able to make those decisions and practice ethical responsibility, right? So we also know that things don't come to us in a pretty picture, right? There are definitely ethical issues that as rehab professionals and practitioners, we are going to interface with. And so I don't know about you, but there are times when we admit an individual, they admit to our program, and they don't have a great discharge disposition, right? Not all of the clients that we serve or patients that we serve come to us with a pretty bow on top, right? We have to identify that there are suboptimal discharge plans because there may be limited resources for funding, or there may be unsafe environments, right? And or inappropriate discharge environments based on the psychosocial issues, the dynamics involved with the family. The list can go on and on and on, because I would bet many, and I'm not a gambling woman, but I would bet many that 99.9% of you on this call have faced challenges when it comes to discharge disposition and or discharge placement for individuals, right? And then there's also the decision-making capacity, right? Their ability to give consent. And as we're going through the continuum of recovery, there are different aspects of that. We make our clinical recommendations, and we'll talk more about this throughout the next few slides or towards the end of the presentation. But there's definitely those challenges where we have specific dynamics where the patient or the family refuses our brilliant recommendations. And so that becomes very challenging. And we come from a place where we feel like we know best. We're the experts in this field. We've seen this time and time again. But this is a new case that we're working with, right? These are individuals that have not had the level of education, the level of exposure when it comes to rehabilitation and recovery, and they have their set ways, or it might be cultural, where we face some resistance and healthcare mistrust, right? That challenges us to be able to get to the end goal. And it also might be our own biases, right? That's something to take into account as well. It might not necessarily be because of the patient or family, but it might be our own biases and what we feel like a lifestyle and an environment should look like. And so those are obviously some ethical issues that we face. There's also within the interdisciplinary team, there could be some team conflict, right? Just as I was talking about our own biases, there could be individuals on the team that feel like this would be in the best interest of the client and of the family, but there are differing opinions, and there are decisions to be able to be made to have a consensus on our clinical recommendations, or the physicians, right? We have multiple physicians involved in a client's care, and all physicians may not be on the same page. And so we have to be able to work through those ethical issues that arise. We've already kind of talked about the compliancy versus the refusal, which is a thing. And then also the decision-making capacity. Again, we'll kind of dive into that a little bit later. And then there is also always the truth-telling regarding the prognosis. And the interesting thing about truth-telling is that as an individual goes through the continuum of care and is in different phases of their recovery, that truth-telling may change, right? And or sometimes that truth-telling is not told, right? So there's so many different layers of that. So, oftentimes in that ICU, acute setting where they don't know if the individual is going to make it, right? They don't know if they're going to be able to, and if they do, they don't know how much recovery they're going to be able to obtain, given the severity of the injury and the complexities involved. And so it's important to think about where that family is coming from, right? They have, the client's been given a second chance, they have an opportunity to recover, and where, weeks before they were telling the family that they didn't think they would make it through the night, right? So we have to remember that in the different phases as they go through the continuum. And then the other component of that is when they reach that post-acute level, they might have been told different things, or it might have been consistent throughout the whole time. But now we're talking about long-term goals. We're talking about reintegration into the community. We're talking about being able to resume previous roles and responsibilities and employment status and driving status. And there's a lot of truth telling that has to come with that, right? And it may not be a not ever, but it may be a not now, based on the cognitive impairments or the emotional adjustment issues or the physical limitations that the individual faces. That prognosis may not look good for an immediate short-term goal. And we have to work through that as we talk to the individual about potentially not being able to return to work, or maybe being able to return to work, but not in the same capacity or not in the same field, right? Those are some truth telling regarding the prognosis for those short-term goals that we oftentimes deal with as well. So when we're looking at ethical decision making, I wanted to present a model that can really be used as a case-based approach in clinical practice. It is Johnson's 4 boxes. So the first 2 boxes are medical indications, principles of beneficence and non-maleficence, and then the patient preferences or references, excuse me. This is really focusing on the principles of respect for autonomy. So when we're looking at medical indications, as I was talking about, what are the goals for treatment? Short-term goals, long-term goals, and ensuring that we have client-centered approaches when we're identifying client goals, right? We want to be able to enlist and involve the clients and their families as to what their goals are, because we as clinicians have our set goals, right? We want to be able to focus in on ambulation and on communication and social pragmatics, and we have these buckets, right? But we have to really be inclusive of the client's goals and their preferences and beliefs and cultural systems to be able to make a well-rounded treatment plan. We also have to look at the prognosis and the level of acuity, right? And chronicity of these injuries and illnesses. And then also potentially looking at the probability of success, the benefit to the patient, right? When we're working with individuals that are going to be placed in a long-term care facility versus someone that's returning to work, our goals should look very different, right? And the time frame in which we're treating those individuals should also look different. Then when we're looking at the principles of respect for autonomy, we want to know how well informed was the client, right, the patient. What level of comprehension do they have based on cognitive assessments? And then being able to ensure that we're allowing them to participate. But we also have to determine, are they participating because they have a guardian and they don't have the capacity to be able to make a decision to say no to the treatment? Or are they a willing and voluntary participant in that treatment, right? And we know that that sometimes can look very different on outcomes as to the level of buy-in and motivation that the client or the patient exhibits. We also want to always look at mental capacity, right, and their legal status. And so when we look at admitting a client, we want to know, do they have a medical power of attorney? Do they have a guardian? And we'll be able to talk through all of those fun things today as well. And then also we want to talk about, do they have an advance directive and have express preferences and a surrogate? So the last 2, the third one is quality of life, principles of beneficence, non-maleficence, and respect for autonomy. Now we also want to take a look at the contextual features, principles of justice and fairness. So quality of life, right? Let's look at what does it look like if this individual continues to receive clinical interventions versus if they go home with some type of aid and do not receive any type of therapeutic intervention, right? We want to also look at the potential and the prognosis of, if we request this authorization and this funding support for this individual, what potentially is going to be that outcome? How much further are we going to get in their recovery from their current status to a higher level of functioning, right? Those are the questions that we have to ask. And we have to be able to make sure that we are aware of our own biases, right? Because, you know, I think that at times we think everybody could benefit from therapy, everybody could benefit from rehabilitation, right? But we have to make sure that we are able to really take a look and individualize our clinical assessments to determine how much gains will they make and how long would that take? And or looking at, for example, time since injury, right? Previous clinical interventions, therapeutic interventions that have been, efforts have been made towards, and what were those clinical outcomes? Definitely something to consider. And then might the present or future condition be judged as undesirable? That's another good question that we need to be able to look at. And then the principles of justice and fairness. So are there family issues that might influence treatment decisions? I would say probably yes, right? You know, I think that there is always these dynamics within the family, and that's why we have to be very client-centered from day one to be able to understand who this family is, what was their lifestyle before, what were their support systems, and what did that look like within interfacement with the patient that we're serving, right? And then also looking at the provider, right, that might influence the treatment decisions. And then obviously we're always looking at the financial and economic and allocations of resources, and you know, whether there's a plethora of those resources and or it might be very limited, right? And then how does the law affect those decisions? And then is there any conflict of interest on the part of the providers? So with that model, we want to then also talk about a process, right? We want to be very objective in the way that we're looking at these specific cases. So when we're doing our data collection and assessment, we want to be able to define the type of the problem, the type of problem that it is, and who is involved, right? As I continue to talk about being able to gather facts about the family, about the client, about the values and concerns that they may have, and also doing in this, you know, in this process, we're really identifying, okay, what level of education is going to be needed for this patient and their family, right? Depending again on their level of education, their level of exposure to healthcare, to rehabilitation, that really sets the tone for what we need to do as providers. And then we have to look at the facts, right, within the context of a theory. This is really where we're looking at case conceptualization, right? We need to be able to make clinical judgments based on diagnoses about the care context, right? Feeling out, where are the points of agreement? Where are the points of tension, right? And then the conflicts of obligation or value. And then the outcome, right? We want to look at clinical outcomes, and there's not, it cannot be a cookie cutter approach, right? And we have to understand what would happen if. So if we provide this level of care, if we provide this level of therapeutic intervention, where can we get this individual, and how do we plan our treatment around that? And then what if this individual didn't receive that? Then how do we pivot? Right? So there's a lot of flexibility in what we are able to do, again, based on resources, based on the patient's ability and willingness to participate. And then we want to implement, right? What is an outcome that people can live with, and what is that fitting answer? And then we want to evaluate, right? We always want to look at our clinical outcomes and determine where are we doing excellent work and where do we have some ways to go in getting individuals to move through the continuum of care and to have positive clinical outcomes as a result. And so we always do kind of a post-mortem review of cases to be able to determine how successful was that individual. Could they have been more successful, or did we, you know, when we're looking at our clinical outcomes and looking at our targets of what we set upon admission, how far off the mark did we fall, above and or below, right? So we want to evaluate that as well. So here's a one case example that I know you guys probably were aware that would be coming. So this is a post-acute medical decision, excuse me. This is a 34-year-old male. He sustained a severe TBI 9 years ago, and he was admitted to a neurobehavioral program for identified behavioral issues as a result of the injury, maladaptive behaviors that we are obviously well acquainted with as we work with a certain population. So the parents or guardians, this individual is globally aphasic and has right-sided paresis, right? This individual, prior to the injury, has a long-standing history of significant, I'm sorry, not prior to the injury, post-injury, significant post-traumatic seizure disorder within the past 9 years. And so there was medications ordered for this individual for seizure disorder, as well as a mood stabilizer. And so the client, unfortunately, was refusing all medications. And so we went to the guardians, right, the parents, and said, you know, this individual, we know about the long history of the post-traumatic seizure disorder. You know, there did a lot of education around, you know, anti-seizure medication and how that supports his level of function and the potential risk involved if he were to continue to have seizures. But despite that education, the guardian supported the client's decision. So he fell and hit his head and had a seizure that required helicopter transport. So as a clinical team, we are thinking, okay, this is it, right? Lesson learned. Family is going to be able to support the clinical team's decisions and the medical provider's decision to continue treatment with the anti-seizure medication. But the client and the guardians continue to refuse. The client continued to refuse the medication and the guardians continue to support that decision. Despite education, despite a tragic event occurring that required helicopter transport, hospitalization, set him back, right, from where his baseline was prior to that last seizure. And despite all of those circumstances and all of the efforts and education that was provided, they still continue to support the refusal. So there are definitely times where we feel like we are sticking our neck out, right? Sometimes we feel like we are working harder than the patient. And, you know, there are definitely complexities, right, that are existent within that. You know, there are so many things when it comes to competency and capacity, and really trying to understand, you know, this is our, you know, so there's opportunity for us to be able to take a step back, right? To take a deep breath and to try to figure out why, the whys behind those decisions, right? Because we can make a lot of assumptions, or we can go quick to make a judgment. We can go quick to become frustrated. But when we don't take the opportunity to understand where that individual is coming from and what are their wishes and why, then we have a much harder time and we face much more resistance, and we can potentially break trust, rapport, and then we don't have the buy-in, right? Because all of that is affected. And so we really want to be able to take a look at those medical decisions. Who is the decision maker? What are the client's rights that we'll talk about in a minute? And then be able to talk about education, and clinical recommendation, medical recommendation, talk through risks, right? Talk through safety precautions. But then at the end of the day, we also want to know, where are you coming from and why, right? So that we could better understand that. So there are certain laws. This does get a little bit dry here in this part of the presentation, so grab your afternoon coffee. But there are certain laws that protect the individual, that shape us as healthcare practices and also guide ethical decision making. And so just as our code of ethics guide us, they're there for a reason, state regulations are there for a reason, so are certain laws, right? And I'm happy that we have them, and I think it's a good thing. So laws protecting the individual and shaping healthcare practice. So for common law, I'm going to go through these. I'm sure all of you know this, but I think for the purpose of this review, I think it's important for us to just refresh these different areas. So common law developed from court decisions, medical malpractice, defensive medicine, as we call it, right? And there's the constitutional law, which is based on the US Constitution, as well as the Constitution of the state where the person lives. So that protects the rights of the individual. That's where our civil rights come into play, and obviously the ADA, which we are all very familiar with. Then there's the statutory law enacted by Congress or state legislature in the form of individual statutes, which together form a code. And that's where, again, we're thankful for HIPAA and the ACA and workers' comp, right? Without those, where would we be, right? Don't even want to think about that. So, and then the administrative law, which is regulations created by administrative agencies such as CMS, DPW, Department of Labor, OSHA, and then we also have the accrediting bodies that for the majority of the time are voluntary, right? Such as CARF or JCO. So let's talk about a client's bill of rights or a patient's bill of rights. I use that interchangeably. So, you know, I think that it is important that we talk about that, because I think sometimes when we talk about guardianship, clients' rights get drift away a little bit, right? And I think it's important for us to bring those rights back into the conversation alongside talking about guardianship. So it's a written guarantee of basic rights for persons served. A violation of any of these rights could be unlawful acts or potential grounds for a lawsuit. And so it's important that under the revised, that we all know under privacy violations, that under the revised HIPAA law in 2013, the individual, not just the organization, could be held liable for breaches of the individual's PHI. So that's important for all of us to know, that it's not just, oh, my organization's got this in the event that there is a breach of PHI. It could fall on the individual as well. And then it must be posted in the programs, right? Available for review at all times. So in any residential care facility that you enter, you should be able to find the rights, the client's rights posted, and the client should be able to have access to those rights and have those reviewed upon admission into the facility, as well as reviewed annually. And it needs to be written in the primary language of the consumer, right? And if it's not, then assistance should be provided so that they can fully comprehend their rights. It is an ability for the person's rights to receive respect, timely care by competent professionals. We talk a lot about competency in the healthcare world, right? The right to informed consent, to privacy, to understand what the facilities' rules are, to be able to make decisions and to refuse care. That's sometimes difficult when we're talking about compliancy versus refusals. It can be very frustrating, right, for the client to be presented with something that they are being asked to do. It can also be very frustrating for the clinician to receive that refusal from them, right, or the medical provider, the physician, whatever it may be. But we have to understand that the clients have a right to refuse. And then they also have a right to be treated in a safe environment. And as a staff member, it's our responsibility to bring immediately any potential violations to the supervisor, to the leadership team, to an outside agency, right? If anything is discovered, because failure to do so could make that individual, as well as the organization, personally liable for those violations. So moving on to decision-making assistance, right? So we're talking a lot about guardianship, medical power of attorney, client rights. So the power of attorney, so we're going to talk about power of attorney, durable power of attorney, representative payee, financial guardian, guardian of the person in estate, and then advanced directives. So advanced directives, right? It's a written instruction such as a living will or durable power of attorney for healthcare, which guides care, right? When someone is terminally ill, incapacitated, unable to communicate his or her desires, it's written down, right? And it can be modified at any time. And so hospitals, thankfully, are now asking upon admission for advanced directives and offering this to be completed if not already in place. And I'm still surprised to this day how many healthcare professionals do not have an advanced directive in place. It's a little bit mind-boggling, but it is highly recommended here in this presentation today. So durable power of attorney for healthcare, right? A competent adult, the principal appoints an agent to make decisions about medical care in the event that the principal is not able to make those decisions. And that remains in effect while the person is unable to make his or her own decisions. If it does differ from a living will or an advanced directive because the principal is not giving specific instructions about what to do, but rather identifying that person, right, that's going to make those decisions on their behalf. Most states combine durable power of attorney for healthcare forms with the advanced directive. So surrogacy is a competent person, and the principal appoints another, the agent, to act for him in legal and financial matters. So the agent may have specified broad or limited powers depending on how it is written, and they may be beginning that role immediately and or following an event such as a brain injury. So the appointment may also have durable, which means that the powers do not change when the principals become disabled or incapacitated. And so under most state laws, not all, but most, a guardian can override or revoke the POA. And so staff should be aware of the consumer's POA document and its specified duties. So not only being able to make a copy of it, put it in the patient's chart, but ensuring that all staff are aware of what that looks like. So then when we're working with individuals, there's obviously a lot of informed consent and decision making that has to take place when it comes to the services that are being provided. And so that leads us into talking about competency or capacity, right? So a legal term that's describing a person's mental ability to understand the nature and effects of one's decisions and acts. So the legal age of competency depends on the state, but only a court may determine that an individual is legally incapacitated. So oftentimes within a rehabilitation setting, our staff will be asked, is this individual competent? And we are not, qualified to be able to make that decision. That does have to come through the court. However, at the same time, we can provide clinical documentation, clinical assessment information, right, to be able to share with whomever may be asking on what level are they needing assistance, right? What level of function are they doing? We can give objective data based on assessment measures, right, to determine kind of based on that individual's age and education level, previous level of functioning, where we may feel like they are in comparison to that, right? But the court would be the one to deem that individual incapacitated. And so they will appoint a representative to make the decisions that the individual is not capable of making. And there are definitely areas where the staff should report concerns that a legal competent consumer or participant is not able to make decisions, right? So that's where we involve case management, right? The clinicians are doing their cognitive assessments, and there are decision makings that the patient is making that are of concern and of increased safety risk. We go to the case manager, we talk to them about that. We find out where they are at in the process, if it's already been started, and or if that's something that's going to be a new conversation for those individuals, the client and their family members. We have to start that process because it's important to really think about that. It also comes into play, as we talked about at the beginning, of discharge disposition, right? And being able to make determinations and recommendations for an individual to transition back into their home, into their community, reintegrate back into those roles, and or is it being recommended that an individual, because of lack of resources, because of unsafe environments, is it a recommendation for them to be able to transition into something different, right? Such as a supported living placement or nursing home care, whatever it may be. And at times when those individuals are, their own guardian, but cognitively are not demonstrating capacity to be able to make sound decisions for themselves, that's where we have to get into conversations about guardianship. And so, it's oftentimes a difficult process to understand when, right? When are we going to make that recommendation? When are we going to start that conversation? Does that start in the acute phase? And or does that, do we give time for that individual to recover, to potentially be able to increase their level of cognitive independence and be able to bypass that, right? So, and they do have the right to contest that competency, right? But definitely ethically, we have to approach this together. It's not just because I think you should have a guardian that you have to have a guardian, right? We have to be able to take a look at What is the rationale for that? What is the supporting evidence for that? And then working together with case managers, internal, external case managers and families and attorneys to be able to determine those next steps. But it is an ethical obligation that we evaluate that. So there is medical decisions and informed consent, and those should be, you know, well spoken about, right? It has to be able to be, the individual has to be competent, right? To be able to talk through that informed consent. It needs to be communicated with treatment choices to be able to understand their decision-making patterns of if they choose this path versus this, what are potential consequences of that, right? And being able to provide different choices and ensuring that they comprehend, right, what's being communicated to them. And sometimes there's difficulties, right? The individual is their own guardian, and overall they have a supported system, but we need to be able to talk to them about some medical decisions or recommendations that we're making. And so we want to be able to offer support, right? And give them more time to process the information, to be able to phone a friend, phone a family member, involve their family members to be able to understand what is being presented to them and be able to make those complex decisions. And really kind of understand that sometimes you have to be able to either repeat your information, right? Repetition, and or ensure that it's given in small increments of information so that we're not setting them up to be very overwhelmed and not be able to understand the next step. So guardianship is a legally enforceable arrangement where the person, the guardian, has the legal right and duty to care for another, which is the ward. So a person with a guardian does not lose basic legal rights. And again, that's important, and that's why I wanted to review the client rights. The guardian of a state is focusing on financial matters, benefits, property, the conservator, right? And then the guardians have the right to have input regarding the person's program, medical care, and release of records. So there is partial guardianship that's provided, and that is those limits can be determined in court. So empowered with the authority, right? What is the guardian empowered with? They can select and confer with the medical treatment team. They are authorized to access medical records, file appeals due to denial of medical benefits, speak on the incapacitated person's behalf, apply for benefits, converse and negotiate with workers' comp carriers or other insurance companies, and also retain a lawyer on behalf of the incapacitated person. So again, $1 million question, when do we advise our families to pursue it? And I don't think, again, there's not a cookie cutter answer for that. It is specific to the individual. It is specific to the individual's injury, time since onset, resources, level of education, you know, the list goes on and on and on and on, but it should always be a question, right? So there's not a cookie cutter answer for that question, but the question should always be present, right? Do we advise families to pursue this? And there's times where the answer is no, right? There's a very good prognosis. The client has resources available, and they're not going to be, you know, that's not a necessary step. And then there are definitely times where we need to advise families to pursue it. And then there's also, there's times where there's not a family to pursue it, right? And then what do you do? So we have to involve the court to be able to have a court-appointed guardian for that individual. And so we're pursuing it through the state directly at times. So here's the second case example. This is a 47-year-old man. He sustained a TBI when he fell riding on the outside of a vehicle. And in my 20 years of post-acute neurorehabilitation, I have seen several of these scenarios for nature of injury, and it just blows my mind, right? Typically, we see it at a younger age, but this individual sustained had a lot of damage, right? The left frontal subdural hematoma, subarachnoid hemorrhage, orbital fractures, temporal skull fractures. And he was extremely agitated, which you would probably assume based on the level of injury that he sustained. And so he was treated in the acute hospital with Geodon and Seroquel. And then he was transferred to the ARU for therapy. He had one-on-one supervision. He had a sitter because of, as you would imagine, he was an elopement risk. He was agitated. He had poor safety awareness, poor insight, and those of nausea. He needed cognitive support. And so there were definitely barriers, right? He had intermittent behavioral upset, severe cognitive impairment, limited self-awareness, and mood instability. So he was transferred to a post-acute neurobehavioral rehab program. So he was in the ARU for 2 months and then transferred to post-acute. So on the day of admission, he petitioned the staff to let him leave. And so he immediately, of course, went to the case manager, right? And would repeatedly go to the case manager, right? And because the case manager had direct access to all of the clients and the clients had direct access to the case manager's office, it was a constant thing, right? He was saying he was going to leave the program. He was reaching out to family and friends by phone. He was getting on Facebook, trying to be able to get anyone to come get him, right? And so we had talked with the acute rehab. They had made a recommendation to pursue guardianship at that phase in the recovery for the family. And so a legal counsel was appointed by the court to represent him. And the son was petitioning for guardianship of his father. And at the time of admission to the post-acute program, a guardianship hearing had not yet been scheduled. And so at this time, when this is all happening, he was his own guardian, right? And so the son and the daughter were involved. The court-appointed attorney were involved in supporting that he remain in the neurobehavioral program. So thankfully, we were able to align with the family members and be able to build that trust and rapport to know that this was the best and safest environment for him given his current level of functioning, right? And so they were in full support of us. However, he continuously perseverated on leaving, and he had called his son and the insurance case manager and the lawyer, actually. He called all three of them to let them know that he was going to discharge himself. And so the lawyer was obviously giving him advisement to stay in the program, and that pissed him off, right? He was like, you're supposed to be my advocate. And so he revoked his ROI, and he called a taxi about 7:15 in the evening, and he had his bags packed. He had some cash on him, and prior to leaving, he signed a brief document endorsing that he was going to leave AMA. And so we provided him a supply of medication and the MAR with him to go. And we contacted the son to let him know that his dad had discharged himself and left our program via taxi. And so the family, the son, was extremely upset and upset with us, right? He was saying, why couldn't we stop? We should be able to do that. And of course, we had to talk through in that moment of crises that we were not able to stop him because he was his own guardian. And so I think that there is, those scenarios that happen time and time and time again, and that's where it's difficult, right? There's no crystal ball. There's no perfect timing of when you would start that process and when it would be in place before something like this would happen. But at the time that it happens, although we have behavioral supports and crisis plans and, a secured facility, all of those things, there are times where that individual is going to make a decision against our recommendation, and that is sometimes extremely unfortunate, right? So guardianship and protections, I'm trying to be mindful of the time, and I realize I'm quickly running out of time. So I'm going to go through this pretty quickly because I do want to allow for at least 5 minutes of questions at the end. So these are things from an ethical perspective we need to review: the abuse, neglect, and exploitation. As we all know as well, There are often times where individuals have poor guardianship and or they may have good guardianship at the time, but this recently happened where we had someone that the guardian was aging and started experiencing dementia and was making unsafe decisions, and we had to call Adult Protective Services and get them involved, and are working towards removing guardianship from her, and the aunt is going to take over guardianship. And so, to no fault of her own, she has just, it's been, this individual has been injured for 20-something years in our supported living program. And unfortunately, we've had to be able to make some decisions for the sake of the client, but also for the sake of her and her own safety as well. So the ethical considerations with aging is quality of life, medical comorbidities, levels of care, advanced directives, end of life issues, and then of course, we always want to support final wishes to include religious and cultural beliefs and preferences. And so we need to be able to do that as an organization. Even if there's not advanced directives, we want to be able to understand what the client's final wishes are. So there's risk involved, right, when we're working with individuals with diminished capacity. And so as our generations continue to explore more technology, that's a big one, right? The use of social media and the access to individuals, community access virtually, which we didn't have, as much 10, 15, 20 years ago. So there are definitely, I just listed off some, the list could go on and on and on, right? But when we're looking at the risks versus the benefits, we really have to be able to take an ethical committee together to talk about what are the pros and cons to this individual pursuing these things, right? So buying a bride from Russia, right? Probably not in the best interest of the individual and is a very high risk, right? This happens very often, sending money online, having, that's where we have to put together a plan with the guardian, the fiduciary, the conservator, all of those individuals to be able to make sure that we are limiting the individual's access to their own funds for the benefit of the client, right? And we have to be very careful with that when it comes to rights. And we have to ensure that we're aligning with the conservator to ensure that financially this is what they feel like is in the best interest of the individual. There's definitely opportunities for individuals to get into a place even before they come to us, and then they come into our facility and they've been living independently, but it's not been going well, and then there's a level of restriction that they feel, right? And then there's definitely driving risks involved. Again, we could spend probably another hour talking about all of these related risks, but I want to be mindful of the time. So, I think it's really about understanding and identifying the risks that are involved, but also looking at supportive failure in a supportive environment that's safe, and being able to take risks on small things so that they feel some autonomy to be able to make some decisions for their own selves. We want to be able to set those objectives to achieve goals, identify supports, make sure everybody is aligned with the goal. And we have to understand that that's going to be an evaluation and an adjustment and flexibility, and okay, back to the drawing board, that did not work out well and these are the reasons why, but what if we tried this, right? And so really having some flexibility around that. It's definitely a risky business, right? So we want to be able to maximize our funding, our resources, our relationships to ensure that we are all working together collaboratively for the greater good of the client that we're serving. And there's definitely some plans for care considerations that we need to do, looking at all of the things that we discussed, right? This is just kind of a summary of discharge disposition, funding for the care that's being recommended, what level of care is needed, what is the consumer's role in the plan. All of those considerations are important. And then there's also tools and documentation. So policies, education, right? Determining capacity, and advanced directives and strategies and support for community integration to support the risks that are involved with this area that we do. So tools and strategies. Again, I mentioned the ethics committee. I think that's a great forum to be able to review some ethically related cases where we need to have a multitude of professionals, experts involved to be able to take a look at those decisions that were made and or are going to be made. And just being able to have that promoting that client-centered care, but also consumer-centered decision-making as well. And then at times there may be a need for a consultant, an external consultant, to be able to review the ethics that are involved in the programming that's being provided. So thank you very much. I'm sorry we only have 3 minutes left for questions. I apologize for that, but let me pull this up and see.
Well, thank you, Paige. Thank you so much for being such a wonderful speaker. And there's just a lot of great information. And maybe we can ask Rhonda to come back and ask, maybe we have some questions you could answer for us.
Heidi, you know, I do have a question that is frequently asked, and I apologize, I am not able to turn on my webcam for some reason. But a question that is frequently asked is, how do you best support and educate families in allowing them to understand the need for guardianship?
You know, I think that's a multi-prong approach. I don't, you know, as I continuously say, I don't think that there's a cookie cutter answer, but I do think that one, it's trust and rapport with the family, right? We're making these clinical recommendations for the sake of the client, and that may not always be something that the family wants to hear, right? Because they have this hope and optimism that the individual is going to recover miraculously, and that this won't be an issue or this won't be a path that they have to take. And so first and foremost, we have to build that therapeutic alliance with the client. We have to build that trust and rapport with the family members so that they can truly hear us and know what recommendations that we're making based on our level of expertise. In addition, we have to have some supporting evidence, right? Because I think it's important that we don't take this lightly, that we don't, you know, this isn't just an easy decision or recommendation. So what we want to be able to provide is more clinical evidence to support that. So our clinical assessments and really comparing that to the individual's level of education, time since onset, severity of injury, age, prognosis, all of that information should be in educational forums with the family members to allow them to understand the severity of the deficits and why that's being recommended. And then another approach to that is also having a neuropsychological evaluation, right, which is going to go into even more in-depth assessments than what we do within our clinical team. And so within that, the neuropsychologist can also make the recommendation for obtaining guardianship based on, you know, the lack of competency that they are seeing within the evaluation. And that feedback session with the client and the family is crucial as well. So they're not just hearing it from one source, they're hearing it from multiple sources to support that clinical recommendation to obtain guardianship, for sure.
Oh, great. Well, thank you so much. And if anyone needs to contact Paige, please refer to your handouts for her contact information. And thank you everyone who joined us today. And just as a reminder, you will be receiving an email from GoToWebinar with your certificate. And if there's anything we can do for you here at MacroPro, please let us know. As a reminder, we're a document retrieval company. We gather records for your claims and litigated files. We can get the records here in the United States and also worldwide. I hope to see you all next at our next MacroPro and Friends event. Enjoy the rest of your day, and thank you. Bye-bye.
Thank you. Bye.
Bye. Thanks.